Hi, I'm Dinesh Sivaratnam. I'm the Director for Nuclear Medicine at Cabrini Hospital, and here together with me today is Associate Professor Jeff Lefkovits, who is the Director for Interventional Cardiology at the Royal Melbourne and also an interventionalist here at Cabrini.
That's right.
We're talking today about the management of heart disease during the COVID pandemic. Jeff, how has the COVID pandemic affected management of heart disease?
Well, just to start off with, you might have seen an article in the Age just last week about a man who had symptoms for 5 days before he presented to the hospital, with the message being that people had seemed to be delaying coming to the hospital. And in fact, what we've noticed over the last few weeks, both here in Melbourne, both in the public and the private sector, and also around the world, is that there's been up to a 50% reduction in the number of people presenting to hospital with acute heart problems. And this may be due to a number of different factors. It might be due to environmental things, they're less active, or maybe even things like pollution in the air. But what we really are concerned about is that people are avoiding coming to the hospital, either not to overstress a hospital that's already under pressure, or also potentially worried about getting an infection in the hospital. And we're concerned that that's going to have some both short-term and longer-term adverse health outcomes if people don't come to a hospital when they've actually got symptoms.
So what would your recommendation be for patients who have got acute chest pain or become profoundly short of breath suddenly?
Well, I think my advice would be to follow the roof bodies like the National Heart Foundation and many other bodies such as the Cardiac Society of Australia, the specialist bodies, the GP bodies, all say that you should not ignore a medical emergency. And so basically, people who've got symptoms such as concerning chest pain, shortness of breath, palpitations, symptoms are getting worse and coming on more quickly, lasting for more than 10 or 15 minutes only, they should be calling the ambulance, calling 000, calling the ambulance, and then letting the ambulance assess them. And if necessary, transferring them to an emergency department so they can receive timely and appropriate care for their condition. And I guess I'd also reiterate that any concern that there's of catching COVID by coming to an emergency department is extremely low and really not and should not be taken into account if the person's got acute symptoms.
Jeff, how would you advise a patient who is not really having an acute symptom development, but who is having more of a grumbling, low-grade development of chest pain or shortness of breath? How would you advise them to manage it in this period?
I think it's important to tell patients that they must stay connected with their GP, and that during this time when there's all these things going on, the GPs are open for business and that they're available. Now, how that works depends on each general practice, I suppose. And so our advice is that if people have got symptoms, new symptoms particularly, that they're not sure about and not quite as bad necessarily as to call the ambulance, that they should be contacting their GP, and the GP will advise them whether that's via telehealth or via face-to-face, and will deal with the problem, with the assessment and the management of the problem as appropriate, and to let people know that the GPs still have access to blood tests, they still have access to various investigations, and if necessary, they can refer on to specialist cardiologists for an opinion. But now, on that question, Dinesh, let me throw back to you. And how would you advise the GPs in this COVID area? How should they be going ahead and managing patients that are coming along with new symptoms?
The same way as they would normally. I think they might elect to do it via telehealth. They might do it face-to-face, or they might do a combination of the two. If they feel that the patient needs more investigations after an initial telehealth interview, they can organize that, because pathology services, ECGs, and outpatients non-invasive assessments of cardiac function are very much open for business. And here at Cabrini, the nuclear cardiology service is up and running. We can certainly quickly and effectively assess and help the cardiologist or the GP triage patients into either having medical management or needing more intervention at this point in time. But the bottom line is the service is up and running, and it is here to assist the patients, the GPs, and the specialists of the hospital and within the community in general.
So Dinesh, are there any circumstances now that a patient who would otherwise normally be referred for a non-invasive test should not be, given the current COVID situation?
Sure, I think considering we're within the pandemic, uncontrolled infection related to COVID or any other type of infection would be a preclusion of us proceeding with a stress test. And then the usual contraindications of uncontrolled heart failure, unstable coronary artery disease, all of which really will be picked up by your GP or your specialist. And in case it doesn't, it certainly will be picked up in the Department of Nuclear Medicine here at Cabrini, and hence in those instances we will not proceed with the test.
So following on from that, Dinesh, so on a practical level, what is available for testing, non-invasive testing here at Cabrini, and how would people go about organising it?
Sure, the usual non-invasive tests are available, and they're quite simply organised through your GP or your cardiologist, whoever you're dealing with at the moment. Nuclear cardiac services for sure are open for business at all time, easily accessible, and a GP referral or a specialist referral and a simple phone call to the department will get you in for your test pronto.
And can I ask, is there any difference between exercise thallium scans and persantin thallium scans and pharmacological tests?
None. The accuracy of both are essentially the same. If people can't exercise, then we use a pharmacological stress test, but certainly when during this period of COVID, we're performing both forms of stress testing and both are available.
And can I ask you, what would you advise people, if someone were going to, under which circumstances would you say that a person who would normally be referred for a stress test should not be referred to because of the current COVID situation?
I think anyone with untreated infection shouldn't. That includes people with symptoms and signs of COVID, but of other types of infection. And then the usual precautions, people with decompensated heart failure, people with unstable coronary syndromes. But certainly we will not undertake a test if we deem it unsafe for the patient. So Jeff, in this current pandemic, how would patients with established coronary artery disease be managed?
Well, the good news here is that I think that outpatient cardiology lends itself quite well to telehealth. So obviously in this particular time, most of the cardiology specialists are dealing with their outpatients in a telehealth. And I would say that it's basically a coordinator or a shared model of care between the cardiologist, the GP and the patient. Again, so in this era, it's certainly possible to treat conditions we can still prescribe medications as needed. We can still organise tests as we've just discussed. And although, more procedural work such as angiography and angioplasty is being performed less frequently now than it normally would in order to sort of not overburden the hospital when it's trying to cope with any potential, emergency cases, both angioplasty and so forth, they're all still available if necessary. And that will be a issue that will be dealt with between the patient, the cardiologist and the GP altogether.
So Jeff, topically, lots of people are asking what should they do with their angiotensin converting enzyme inhibitors and ARBs and non-steroidals in this time of COVID and the risk of infection with these drugs?
Yeah. Well, there's certainly been a lot of discussion and, could I say, noise about the use of blood pressure medications in the COVID era. And the issue here is particularly, as you mentioned, with the ACE inhibitors and the angiotensin receptor blockers, that can lead, at least theoretically, to the upregulation of a receptor called the ACE2 receptor. The ACE2 receptor is important in that it's the portal of entry of the COVID virus into the cell. So at least in theory, there's a risk that by leaving people on those particular medications, there are more ACE2 receptors and more opportunity for the virus to get into the body. I have to say that this topic has been very closely discussed and analysed over the last few weeks. Multiple research institutions and roof bodies have talked and published on this. And essentially the message is that there is no evidence at all that these medications actually lead to any harm with relation to COVID infection. And on the contrary, they may actually be a protective effect under some experimental models. And certainly we all know that there are potential risks in disturbing people's antihypertensive medications. Therefore, there's a very strong recommendation at the moment now that people who are on ACE inhibitors or angiotensin receptor blockers for their blood pressure should not change their medications. There is no evidence that it should, and they can be potentially harmful to them. The story with non-steroidal drugs like Nurofen, Voltaren, and those medications is a little bit similar, but not quite as sort of black and white. And the issue there again is that those medications can also cause upregulation of the ACE2 receptor. But as with the case with the blood pressure medication, there really is no evidence at the moment that these medications actually cause any harm in relation to infection. So, and there's been some back and forth with the WHO saying we should avoid them, and then they've retracted their recommendations. So I admit that the whole issue is a bit muddy. But again, to be clear, the message is that there is no evidence that the non-steroidal and anti-inflammatory medications actually are harmful with COVID infection. But if you don't need to take them, and if there is an alternative such as Panadol, then you should go right ahead. But if you are on non-steroidals or you've been recommended to be on those medications by your doctor, you should not stop them until you seek medical advice.